Good afternoon. My name is Louise Bauer. I'm Professor of Paediatrics and Child Health at the University of Sydney and also have a conjoint appointment in the Sydney School of Public Health. I'm also a consultant paediatrician where I head weight management services at the Children's Hospital at Westmead, which is in Western Sydney. And today I'm here to talk about tackling obesity in children and adolescents. The World Health Organization describes obesity as one of today's most blatantly visible yet most neglected public health problems. Others have described it as the public health equivalent of climate change, and still others as the millennium disease. So very strong and emotive words indeed. So why is that the case? And given that this might be an issue, and I'm particularly interested in childhood obesity, how on earth do we start to respond to this problem? So what I'm going to cover in a short period of time, I'm going to address the issue of how much of a problem is child and adolescent obesity. We'll be looking at prevalence globally and in Australia in health systems, and I'll look briefly at waist circumference too. I'll look at the issue of how we treat those who are already affected by obesity. So how does a health system respond and what might be an appropriate way to do so? And I'll touch briefly upon early childhood obesity prevention, the Healthy Beginnings trial. In so doing, I'm very aware I'm only touching lightly upon those issues and completely ignoring many, many other issues. So maybe you can ask some of those in questions at the end. So how much of a problem is childhood obesity? Let's look at global prevalence figures. The International Association for the Study of Obesity has put together a global prevalence map for obesity over a number of periods of time. What I want to point out for you here is, even though I'm only presenting the data on boys, those for girls are also fairly similar. And basically, the darker the blue colour, the more prevalent overweight and obesity is. And they're using here the International Obesity Task Force definition, which at age 18 accords with the adult definition of obesity. So overweight greater than 25 BMI and BMI greater than 30 being equivalent to obesity. So have a look as we go through. Keep a bit of an eye on France because it does something interesting right at the end. But let's look. So clearly prior to the 1990s, we had North America, Australasia and parts of Europe already with significant problem with overweight and obesity, and also parts of South America. In the 1990s, you see dark colouring happening. Australia, parts of Europe, North America particularly affected by this issue, but also the problem starting to be recognised in parts, for example, of China and in other parts of the world, including the Middle East. Here we go to the early 2000s and we can see the problem still an issue in many of those same countries, but hello, here we're also looking at places like India, which are actually recognising that they've got a reasonable prevalence of this issue. Just keep a little bit of an eye on France as we go here, because France alone amongst most other countries has actually had a slight decrease in prevalence. What you can see here is that this is now an issue that is affecting many parts of the Asia-Pacific region, the Middle East, North and South America, Europe and Australasia. So like many other countries, obesity prevalence in children and young people in Australia is high. Let's focus down on Australia here. So for a 100-year view of what has been happening to the prevalence of obesity in Australian children, we go to this really interesting study from people in South Australia, Kevin Norton, Tim Olds and others, who were able to gather together from a huge number of different sources data from measurement of school-aged children over the century, over the 20th century. And put this together here, and what you can see is percentage overweight or obese on the y-axis and the 20th century on the x-axis. And you can see that it was reasonably stable levels for the first 2/3 or 3/4 of the last century. And then particularly around the 1980s, you're starting to see this increase in prevalence occurring. What happened then, we're not sure, but there was probably a range of lifestyle-related issues happening, rise in the types of sedentary behaviours, more quick service restaurants, less active transport, and a whole range of other things, all co-occurring. Or maybe it was adenovirus. That's been one of the possibilities that have been raised. We can have a discussion if you want. Let's look a little bit more particularly in what's been happening over the past 25 years in school-aged children and young people in Australia, and particularly from New South Wales data. These New South Wales data are probably the most carefully and repeatedly done studies. Here, the Schools Physical Activity and Nutrition Survey, and here I show you some data from 1985, 1995, 2004 and 2010, and Lou Hardy has put this information together, and you can see here we're looking at combined overweight and obesity, standard International Obesity Task Force definition, and you can see that there was a rise from the 1980s through to the early 2000s, and then an apparent plateauing. I will actually just comment, however, that those last few measurements are actually done with fairly low participation rates, so only between about 50 to 60% of participation of the school-aged children in the actual cross-sectional surveys. So currently, 1 in 4 children and adolescents are overweight or obese in New South Wales, but that's also the case in Australia. And for obesity alone, we're looking at about 6 to 8% are affected, and it may well have plateaued. But it's not just, BMI gives you a sense of total body fatness, but it also seems that waistlines, abdominal obesity, is changing more rapidly than overall obesity. Let me show you some data from several cross-sectional studies put together by my colleague Sarah Garnett at the Children's Hospital Westmead. So what you can see here, we start off initially just looking at BMI, and because they're of different ages and got boys and girls, it's been adjusted, and what you have here is BMI Z-score. But it works the same way, and what you can see is a distribution. This is where it was in 1985, and just to remind those who may be unfamiliar, a Z-score of 0 is equivalent to the median or 50th percentile. So what you can see here is the BMI distribution in 1985. This is it in 1995, school-aged children, so it's shifting to the right. And here it again is in 2007, and it's actually shifted again a little bit more to the right. And then if you actually look at those, just look at those for the purposes of this analysis above the 85th centile for age, you can see that there was quite a dramatic increase between 85 and 95, but only a smaller increase subsequently to 2007. So that's what's been happening with BMI, body fatness. Let's look at a measure of central adiposity. Why am I interested in that? Because that is what is more associated with cardiometabolic risk, heart disease risk factors, ultimately diabetes risk factors, and so on. And we use waist to height ratio because there's quite a number of studies showing now that a waist to height ratio that's higher is associated with increased cardiometabolic risk, and clinically we use a cut point of 0.5. If your waist is more than half your height, then you're at increased cardiometabolic risk. So let's look at what's been happening to waist to height ratio distribution over that same time period. There it is in 1985. It's shifted to the right, and particularly at the upper ends of that, into 1995, and even further again in 2007. And if we look at those who fall above the cut point of 0.5, we can see that there was an increase from 1985 to 1995, but there was still again another increase further again to 2007. And studies such as this, and it's not just in Australia, but we've got very clear data here, raises the question of whether there's a disjunction between waist circumference or waist to height ratio, which are measures of abdominal obesity, and measures of overall body fatness, BMI. So that's highlighting that, in fact, there is a real increase in prevalence, even though in terms of total body fatness, it may be plateauing at the moment. Now, but are these young people being seen in the health system? Well, we were able to work with colleagues here at the University of Sydney who are involved in the BEACH data set. So this is a study that annually surveys randomly sampled GPs. 1,000 GPs every year are randomly sampled, and they fill in data on 100 consecutive patients of all ages. And with Michelle Kretikos and with the lovely Beach people, we were able to look at data for over 40,000 children aged 2 to 17 who went to their GP for whatever reason. It was largely self-reported heights and weights, and I just mentioned to those who may not be familiar that that means that it's likely to be under-reporting obesity, because people tend to under-report their weight and over-report their height. And I remind you that there was a background prevalence of 23 to 25% of obesity in this population. So if you look at of every 200 children who present to their family doctor for whatever reason, 60 are overweight or obese. 23 are actually obese. That's 11.5% are obese. And one gets offered any form of treatment for that. So it's quite interesting to recognise just how frequently obese children present to their family doctor. But there's other studies, which I'm not going to show you, which largely in Australia but also international data showing that obese children and overweight children present more frequently to secondary level care and also to tertiary level care, and they still aren't usually treated for the problem. Why they're presenting? Possibly because of a range of obesity associated complications, quite minor, even things like fractures and lower limb problems and asthma. We don't know. So, given that there are these people who are already affected, what can be done to treat those already affected by this problem? I just want to give you a framework for thinking about treatment. Those of you who are familiar with treatment of adult chronic disease like heart disease or diabetes may be familiar with the chronic disease care pyramid, where you have a base of primary prevention and health promotion that is going across the whole population. But for those who are affected, you then have this pyramid of care, where the big bulk of the base, about 3/4 of individuals in the community, would actually be managed in primary care or level 1 settings. There'd be a lot of self-care, a lot of community-based care. We believe this model works for obesity too, where there's primary care doctors, other primary care group programs that can be accessed in the general community. Of course, then there's a group of more severely affected people who are high-risk patients. They may have quite a number of comorbidities, they might be starting to have comorbidities, more severe obesity, and they need care management in secondary level care facilities. They are likely to need multidisciplinary teams and group programs. And then there's a group of people who are most severely affected. They'll have complex disease, they'll need individual case management, and they will generally tend to need care in tertiary care facilities, special obesity clinics. There'll be specialist teams and key workers who case manage and join up care. So this makes sense for chronic disease, I think a range of chronic diseases, and I think it makes a lot of sense for obesity. And really we need to have services at all levels. But what are some of the issues in health service delivery in obesity? Obesity is essentially a 21st century disease, and I put it to you that maybe our health systems are still oriented to a 20th century way of service delivery. That's certainly my personal experience in trying to effect culture change. What we see in New South Wales, and indeed what we see in New South Wales, is less so than what we see in most of the other states in Australia and in New Zealand. And from talking to my colleagues internationally, I think this is actually a very common issue. What we have is many services are disjointed. There's bits here and there. There's little coordination between and across regions and between levels of care. Currently in New South Wales, we have a very good primary care level program for people aged 6 to 13. There's no other publicly available community level program for people over 13 or under 6. We certainly have very few services at secondary level care, and we have very, very few tertiary level services. I'll come back to that a little bit. Pediatric obesity and its cardiometabolic complications are essentially new morbidities for most public paediatric healthcare services. When I was a medical student, not quite 100 years ago, but over 30 years ago, we didn't have a lecture on paediatric obesity. In fact, even during my training as a paediatrician, we didn't learn about it because it was so uncommon. Now we have people who work in it full time. And the reality is now that we have many health professionals, in fact I would say most health professionals, are poorly trained in managing paediatric obesity and its complications. So they feel uncomfortable in dealing with it. And there are great issues of access and equity around services for affected individuals. If you live in wealthier parts of, say, Sydney, and your family can afford to send you to a dietitian and clinical psychologist, and not just you, but they get involved in treatment, maybe you'll have easier outcomes than those who live in other parts of Sydney where there's very, very long waiting lists to see overworked health professionals. For example, currently in Australia, only 3 of 6 states in this have actually multidisciplinary tertiary service, and many services have long waiting lists, like up to 12 months for very severely affected people. So this is similar anecdotally in New Zealand and in parts of the United States, and I would think in probably many other countries. So we're not coping well with those who are already affected by the problem. My colleagues and I have been involved in actually looking at the sorts of randomised controlled trials that need to be undertaken. We've in fact undertaken quite a number of RCTs, trying to look at the types of treatment interventions that might be needed. And in fact, the Cochrane Review highlights a large number of these. We're also looking at a range of health professional education strategies so you can start to upskill the workforce. I just want to highlight, of course, that it's not just in all of this that important that treatment pyramid of care has the base of primary prevention and health promotion. And I want to just briefly now talk about one element of that: preventing obesity in early childhood. The Healthy Beginnings trial is a unique study that was undertaken in southwestern Sydney. It's a staged home-based early intervention in the first 2 years of life. Mothers were recruited antenatally from public antenatal clinics, and they had their first visit, those who were randomised to receive the intervention had their first visit antenatally, and then 7 subsequent visits over the first 2 years of life, looking at healthy eating activity for the family and especially for the child. The intervention for those who received it, who randomised to receive it, was delivered by early childhood nurses, and it was undertaken in southwestern Sydney, which of course has some of the more socially and economically disadvantaged areas. The aim was to compare the effect of a home-based early intervention for first-time mothers with newborn babies versus usual care, which is largely one ordinary home visit. The control group received some home safety information but didn't get the home visits as the other group did. We looked at breastfeeding at age 6 and 12 months, and our primary outcome at age 2 was BMI, but we looked at another number of other outcomes. Our findings were published in the BMJ last year, and I just particularly want to salute Li Ming Wen, who was the senior investigator on this, who has really led a really remarkable study. But there's been a whole group of other people involved. Well, at 12 months, we were able to show that there were significant improvements in breastfeeding and other aspects of infant feeding. And at 24 months, there were improvements in the child's fruit and vegetable intake, there was a decreased TV time, and improvements in maternal food and physical activity. But most importantly, because this was our primary outcome, the reason we did the study, there was a decrease in BMI at the time. Let me just show you the BMI distributions of the children at 2 years old. So the blue group is the control group and the red group is the intervention group. And what you can see is the BMI distribution there. And I'll just point out that a BMI of 18.2 at that age is equivalent to overweight, an adult BMI of 25. And the intervention led to a significant decrease in mean BMI of this group who received the intervention, and that was significant whether we looked at a completers analysis or an intention to treat analysis, taking into account all those who are part of the original study. It's the first study to show any impact of an intervention on BMI in early life, and indeed the first to address home visiting. Those who are interested in, please just Google on Healthy Beginnings and you'll be able to take them to a website that has all our protocols available, and in fact the main BMJ paper is freely available, open public access. So what are we doing now? We're following them up at 3.5 and 5 years with a cost effectiveness analysis. Lee Ming Wen is leading that, with Alison Hayes leading the cost effectiveness. Our colleagues, with our colleagues at Fudan University in Shanghai, we've been undertaking a pilot study of using SMS and phone calls to support pregnant women and new mothers, and Mu Li at the School of Public Health is leading that link. And we've also linked up with 3 other early intervention studies to prevent obesity. And we called this the Early Prevention of Obesity in Childhood, or EPOC, prospective meta-analysis. And Lisa Askey from the School of Public Health is leading that, but with colleagues from New Zealand, Victoria, Adelaide and Brisbane. And this is where we're combining individual patient data from 4 Australasian early intervention trials, and we anticipate we'll have 2,000, an N of 2,000 by at age 2 years. We should have all the data in very soon, and we hope to have data being analysed next year. And this will allow us a sufficient sample size to actually look at obesity prevalence rates rather than just BMI. So let me just summarise what I've covered in a whirlwind tour. Child and adolescent obesity is globally prevalent, with the Asia-Pacific region certainly being affected. It appears to be plateauing in Australia and some other countries, but central obesity measures may be worsening. When we think about treating those who are affected, we need to recognise that obese children and young people actually present frequently to healthcare facilities, but they're rarely treated for the problem. And there are many many barriers to provision of clinical care. I didn't go to those in great detail, but there are many. The early childhood obesity prevention is part of the important approach to preventing obesity, and the Healthy Beginnings trial provides the first evidence that early intervention may be important. But there are many unanswered questions about that study, about cost effectiveness, other modes of delivery, and how early is necessary. So many, many questions. But I want to leave you with a final comment in thinking about this. Here we are looking at the International Obesity Task Force's causal web around obesity, looking at all the different factors involved in influencing energy expenditure and food intake in individuals. And you can see this complex web all influencing what happens. Most of the research, most of the interventions that are being tried around child obesity just focus on interventions in either the family and home environment or the school environment and nowhere else. But the reality is that these broader upstream issues aren't really being tackled, and I think that's where the real challenge is in tackling these upstream determinants of obesity. But that means tackling issues such as food marketing, food labelling, food prices, urban physical activity environments, and so on. And indeed, poverty, and so on. But that is beyond the scope of today's particular talk. I want to leave you with some acknowledgements of my colleagues at the Children's Hospital at the University of Sydney and what was Sydney South West Area Health Service, the various clinical research teams I've worked with, and national and international collaborators, and say thank you.